respected faculty and their delegates. Thanks AIOS for giving the opportunity. So my talk is combined surgery, where to choose and how. After listening to medical management of glaucoma, ocular hypertension and Madam's extremely well presentation by tube surgery. So we'll go to now the combined surgery by simple trabeculectomy with cataract surgery, where to do and how. So as you know, simultaneous presence of visually significant cataract and medically uncontrolled glaucoma, having advanced glaucomatous optic nerve damage or visual field loss, we are prone to tend to go for the combined surgery. A combined approach has the advantages of reduced overall cost, reduced anesthesia and surgery time, and less recovery time. Individual patient approach is the most important. The severity of glaucoma must be taken into account for all cases of cataract surgery in a glaucoma patient. In case of a refractory glaucoma, when more than 3 drugs are required, with the associated very early stage of cataract, it is advisable to postpone any phacoem elevation procedure until after glaucoma surgery. And also same time, the cataract genesis effect of the procedure should be considered also, because after trabeculectomy, there is a high chance of the increased cataract genesis. Moreover, cataract extraction performed after a filtering surgery may lead to reduction of the bleb function also. So that's why the problem is when to do the combined surgery and why to do, because if you are doing the cataract surgery after the trabeculectomy, the bleb function may reduce. So that is individual case approach, as I told you. So I will show some cases, like this is one of my patient, the PSCG patient. You can see the layer of atrophy, etc., sphincter atrophy, and the anterior chamber is very shallow. The patient's highest basal pressure of 43-42 mm mercury with right eye 0.8 cupping. And when patient comes after 4 months, that day pressure was 33-34. So why I asked, because patient has stopped all the medications 4 days, because patient has to come to doctors. Even after our repeated counseling, when patient comes from remote places, they don't understand sometimes the language. Even due to our busy schedules, busy OPD, the counseling may not be proper. And maybe they had a financial issue, and maybe they had a compliance issue. These are the 4 drugs patients are using. So in these cases, if you will do the cataract is grade 2 nucleus disease, I think for the cataract surgery or trabeculectomy, and thinking about the compliance and the financial issue, we may go for combined surgery. One patient, poor compliance, lost follow-up from remote area. Her only son is working in a Bangalore distance, and patient doesn't want second surgery. So we may think for this. Here is one case, a PSCG patient. After 3 days, there is a CD, and on 10th day, you can see that CD got resolved, but with steroid, etc. But due to the shallow AC, the cataract genesis in anterior capsule started, and in 1 month, you can see that the visual significant cataract. So I thought I could have been think for the combined surgery in the case, because if you do cataract surgery now, the vision is very much less here. So there is a chance of bleb failure. Here is another case with pseudo-explanation with CRB with NVG. After giving the anti-VEGF, we did the trabeculectomy first. So at that time, the cataract was not significant, and you can see there is a good, SC maintained, and but the bleb was good also. But after 1 month, the cataract genesis enhanced. You can see the depth of anterior chamber is less. Still, the bleb is working good after 3 months. But you can see there is some anterior subcapsular cataract. So these are some patients. You cannot explain now why there's so much cataract, because there is some inflammation in posterior segment. We have given the anti-VEGF, etc. There is pseudo-explanation. Okay. So in those cases, if you think retrogradely, we will think that we might have gone for the combined surgery, because once you do cataract surgery in the cases, the chance of bleb function is may be reduced. So combined surgery today, it either with the trabeculectomy with or without MMC, what is the gold standard. You can go for the tube also now in some secondary glaucoma. And phacoem elevation with the MIGS after evolution of minimal invasive glaucoma surgery in mild to moderate cases, or in some cases I will tell now. So there are 2 to 3 approaches. We can go for combined surgery. As you know, the hypertensive effect of the cataract surgery alone is by just 2 to 4 mm by variable period 1 to 7 years. And phacoem elevation with the trabeculectomy is still the standard treatment of choice till date. And the MIGS up to 40% reduction of IOP is expected. So preferred in mild to moderate cases of glaucoma, POAG, pseudo-explanation, and pigment dispersion syndrome. And combined surgery, trabeculectomy with MMC, with or without MMC, in moderate to severe glaucoma, it basically reduces the peak of IOP. Complication may be more, and premium IOL you may even not put, because there is advanced glaucoma, there is contrast issue. But in MIGS, if you are thinking for the mild to moderate cases, where the that means you are expecting less complications. You can want to avoid the topical drugs because the patient has compliance issue and the cosmetic issue, and you can think for the premium oil also. But the thing is that here the familiarity with the technique required. You should have the good microscope with the angle changing scope, and the surgical gonium lens, and surgical manipulation angle you want to do. So some skill is required. And there are some publications coming out, RCT, etc., with the eye stent. The number of eye stent you will put the decrease of IOP will be there, and they're coming with the promising results. So I will show you how to do a simple trabeculotomy with that means phacoemulsification. There are multiple options. You can go with the same site as in morning session someone described, with the same site and different site. Some different same site is some disadvantages like more complication, the chances of blade failure is there. People are doing with the SICs also. But as I do phacosurgeon, I am a phacosurgeon also, so I do always my two sites like superior trabeculotomy with temporal phaco, so that there is minimal that means complications or minimal inflammations are to the trabeculotomy, or wound healing is good. Here the patient is 70-year female, 100% advanced mixed mechanism glaucoma, vision is 6 cystic, grade 2 to 3 nuclear cirrhosis, on 4 medications and 4 compliance. So we did for the combined surgery, the superior trap first, as someone told, first you will do the cutter surgery, then you go for trabeculotomy. But the thing is that if you first do cutter surgery and without going for the flap raising, so there may be difficulty in flap raising in trabeculotomy due to some hypotension, etc. So first go for the till the flap without entering the anterior chamber. Then you can shift your position if you are doing the temporal phaco. So here is my the flap. You can go either way, like that is limbal based or furnish based. With the furnish based flap, and you have to do the minimal that means tissue damage. I usually put 0.02% mitomycin in simple first time trabeculotomy, if you not secondary glaucoma or repeatability, and quadrangular flap I usually made. And you can lift the flap with either crescent blade or blade breaker with 15-number blade. So with handling, although I am holding it seems speculum, but you can hold with any speculum without damaging the flap. Flap should not be thick or thin, as you know. And without entering the anterior chamber, I changed my position to the temporal that means side for a phaco. And here there is mixed mechanism glaucoma. The anterior chamber are not so shallow, but also not good depth. So in this procedure, so we have to think for the wound site, that means the descent detachment, like in the bent needle, the system side. And so clear corneal phaco you want to prefer, because you don't want any that means inflammations on the conjunctiva, or second trap may require. And there may be some if you are doing in PACG patient, there may be some other complications like anterior chamber shallowing, etc. You have to do put some good
I would like you to conclude since your time is up.
Sorry?
I would like you to conclude since your time is up.
Sorry?
Time
is out.
Yes.
Okay. So first I am doing first. So after putting the lens, you will sorry. And you will put two corner suture, and I put then one releasable you can put in combined surgery, because hypotony may be expected. And after I put the wing suture with tangerine nylon, and mitral suture I put for anterior lip, that is double secure. And you can see that there is a good bleb forming. Okay, with finishing the surgery. So there are some helping tools. You can do AIOCMTC2 UVM to know the lens vault, etc. There is a relative lens vault. You can measure this, because nowadays only lens vault or anterior chamber depth is not the point, because lens vault is from the slash plot to slash plot, this height to the lens apex, and in comparison to anterior vault, the relative lens vault, it is important. You can take out the UVM. So age, severity of glaucoma, types of glaucoma, degree of cataract, and what are the highest baseline IOP, number of medication patient is on, patient compliance, and obviously the surgeon's competency and comfort is taken into account into the combined surgery. Thank you for your kind attention.
Thank you, Mr. Nayak. It was a great talk.